Today we have a talk from Dr. Gibbon, or Libben, sorry, who's a resident at the University of Colorado. He's from Arizona, did his training at the University of Arizona, and then he's been a resident here at CU. He's been doing a research project with Dr. Austin and some other folks, some of the faculty, about transitions of care and how we can do better in terms of easing the transition and losing less medical continuity when people leave the hospital, go back to outpatient care. He's going to tell us about that project. Thank you very much for speaking with us.
All right, thank you. Afternoon, everyone. So that's basically the summary of what's going on. In particular, it's been a project I've been working on with folks at the VA, helping out veterans who are hospitalized here at the inpatient service here at Rose. Something that I sort of jumped on and helped create a little system for. Thinking about transitions of care, it sometimes feels like a game of hot potato to an extent. So going through disclosures, I think that's necessary to do for these things. I don't have many other than that. I said I'm a CU resident, specifically in primary care. I owe a lot of money to the Department of Education, and I'm not trying to sell any particular product or market any product during this presentation. Outline of what we're going to be doing today. We're going to be talking about a little bit about transitions of care in general, where everything stands nowadays and what's been going on. I'm going to briefly go over the work that was done prior to me coming onto this project, sort of the background work of what happened in the transitions of care process between the Rose and VA. And they're going to talk about our intervention that we put in place. So, transitions of care. This is a little diagram I found on the internet talking about all the different spokes of the wheel that happens from the center point, the patient being hospitalized, the veteran in this case, to every other point in the hub of the wheel, although it really more looks like this when you think about it in terms of how everything is supposed to communicate, and it's can be a complex mess. So what makes good transitions of care? Going back all the way to 2007, there are a number of things that Society of Hospitalist Medicine put out. Sorry, I got to keep my head turned this way. About what should be involved in good transitions of care. I highlighted a number of things in different colors, and I'll get into that why, but they're really important points, such as communication, education, empowerment of the patient, having a multidisciplinary approach, and having a multimodal approach. Reconciliation not only of medications, but of everything else that's needed is an important part of the process. And as we move through the years, it's continually touched again. About in 2009, these 6 organizations put out their own statement of what should compromise good transitions of care. Again, accountability, communication is important. Having a multimodal approach, having empowerment of the patient, and multidisciplinary approach, all important parts of transitions of care. And also a list of national standardized metrics, highlighting and touching the same things: communication, multimodal, multidisciplinary, and patient empowerment. And going as far more recently to 2013, we look at what was put out, a review topic about, first of all, things going from the hospital, what should happen to make good transitions of care. Again, same things being highlighted on: communication with PCP and involving the PCP that describes that multimodal approach. Notifying the PCP, completing discharge summaries at the time of discharge. That's an important statement. It's part of what we've been doing with our project. Scheduling follow-up and ensuring prescriptions are available. And for the PCP's end, it involves things communicating again, outreaching to the patient through telephone calls, ensuring that there's follow-up, coordinated care, and the like. So, what is the evidence behind good transitions of care? So, we do know that from a number of studies that poor transitions of care leads to generally poor outcomes. Threatens patient safety, increases costs both in the short term and in the long term, relative long-term, 6 months, as one study looked at, had meaningful cost avoidance. And undue burdens. This was a small study out of Oklahoma looking at 17 patients over 4 months, found 68% of medications are admitted, or prescribed medications were admitted. About a quarter of these were cardiovascular medications, and there were a variety of reasons why they were admitted. Either it was non-adherence, it was, admission that was not purposeful, or it was for a reason such as not reminding the patient to retake their home medication that they were supposed to be on. So good transitions of care. The results are mixed. The generally benefits early follow-up from a number of studies. Patients who lack timely follow-up were 10 times more likely to be re-hospitalized, and it also increased the index length of hospitalization stay. I will point out the one negative study because I think it highlights some important points. In this study, it was looking at 30-day readmission rates in older adults who had 7-day follow-up within 7 days or after 7 days. Didn't really find any difference between the two groups in terms of 30-day readmissions. And things that they point out that are appropriate is there's likely to be multiple components involved in good transitions of care, as well as a comprehensive transitions program is what's important. So this graph, this is from 2013. Something I think is very important to point out how we are doing in the current environment of transitions of care. So about half of patients don't have a follow-up appointment scheduled, and they have difficulty with their medications from some point for some reason, whether that's not understanding the medication or not being able to fill it. A good number of patients don't know why they were hospitalized. They had test results that were still in process, and they had readmissions related to their medications. Less than a quarter of PCPs knew that their patients were hospitalized, and 20% of patients had readmission within 30 days. Now that's huge, and I'll get into that in a second, but that's a pretty big number. And one thing that caught my attention looking at all this was 12% of patients had their discharge summary at the time of their follow-up appointment, which is very important coming from a primary care perspective, as I am knowing what the heck happened while they were in the hospital and not really knowing that can be problematic for a number of reasons. So, let me see. So why is that 20% important? So does everyone know about the Institute of Medicine report, To Heirs to Human, where they looked at stuff, and I think there was important and interesting statistics out of that, saying that if we were 99.9% good in other industries, for example, the airlines would not land at the correct airports, hundreds of correct flights would be missed. The post office would misdeliver thousands of letters every year. So in that study, they made a big deal because about 2.9 to 3.7% of hospitalizations were complicated by an adverse event. Now compare that to the 19 to 23% of adverse events that occur after hospitalizations, about 6 times greater. So that's why there's been such a big deal made about this process. And also because it costs a lot of money. $17.4 billion, about 15% of Medicare money for hospitalization payments back in 2004 were related to this. I'm sure that's higher now. A good majority of these were found to be things that were preventable. So, of course, there are factors associated with complications after the patient is discharged. None of these very surprising. Language barriers, social barriers, cognitive or mental health barriers, even people who are the average person on the street. There is some difficulty with understanding treatment, diagnosis, and that sort of thing. So there's also been something else going on. I'm not sure if anyone's aware. It's been in the news a bit. I'm not sure if any of you have heard it. It's called the Affordable Care Act. So what this has meant for both from the hospitalist point of view and the primary care physician's point of view is that there's been pressure on both our sides to improve this, because there's a lot of adverse events, a lot of areas that can be fixed, and a lot of money that is wasted consequently. Hospitals have been pressured for reduced 30-day readmissions, and from primary care physicians' end, they've been pressured to increase monitoring of their patients with patient-centered medical homes and accountable care organizations. And so what basically happened here is that we sort of had an understanding or sense that something was bad and we needed to improve the system. We never did, really, and so the government subsequently came in and put in some regulations that may or may not work, but certainly do increase a lot of burden on us. And with Medicaid expansion, will likely worsen the fragmentation of our system because of this. What's going on, really? Why didn't we step in and fix this? This is an interesting study I found in 2014. Basically did semi-structured interviews of safety net primary care leaders in California and tried to figure out what did they feel was the limitation to why this transition of care process wasn't going well. So one of the things were financial incentives that they point out. They said hospitals were rewarded for reduced readmissions versus shared savings with primary care physicians. They saw this as a lot of increased work and responsibility without reimbursement. And on the hospitalist side of things, at this time, they were hesitant to collaborate with the PCPs because they, in these safety net clinics, because they saw this as leading to potentially more uninsured patients coming to their hospitals. There was competing priorities between the two and mismatched expectations. Primary care physicians generally feeling undervalued. There was little effort made to contact them, and there were unrealistic expectations placed on them that were felt that they could do given their limited strained clinic capacity. And a number of relationship building and EHR sharing problems. So one of the big things here to think about it in terms of problems is what's going on. What is causing all this problem? And so anyone know this movie? How about the actor in the front? What's that? Exactly, and he's trying to escape again, and what does the warden say at this time? Do you remember? Anyone remember?
Yeah, we have failure to communicate.
What we have here is a failure to communicate, and that's what we essentially have here in our healthcare system. Between this really, this communication is not going on very well. So electronic medical records, weren't they supposed to fix all this? They were supposed to reduce the amount of paper we use, certainly help billing, but also they were supposed to increase communication because everything was electronic now and faster speed of light. So that's fine, but that, if there weren't too many EMRs, but there aren't too many, right? Are there? Like when we're talking about our project, there's these two, and this one, and this one, and this one, and this one, this one. These, a few of these, this one, this one, this one, this one, a lot of this one, this one, this one. Yes, I think we're getting to the end here. Oh, so there's still more. This one, 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 and this one. All of these EMRs, and that was probably not surprising to anyone. So we sort of have a broken communication system. And when we talk about EMRs, we also talk about technological interventions to try and improve our communication. And a number of studies have tried to look at various technological interventions, none of which help too much. Even when we look specifically at EHRs that communicate, this is a 2014 study, a group practice who's had their EHR since 2006. Outpatient and inpatient were different, but the outpatient one could extract information, so they set up all these interventions, such as it notified the PCP at the time of discharge, It sent over the MedRec and drug interactions, recommended dosage changes, laboratory monitoring, and even set an alert to the PCP's office to schedule a post-hospitalization follow-up. And the outcomes were pretty unsatisfying. No decrease in 30-day readmission with this. No significant effect with all these EHR interventions. So obviously this is not the solution, although it'll be interesting to note that when I talked with the VA attendings across the street, they all said, well, you can easily simplify this by having everyone be on CPRS. But I don't think that's going to be a realistic solution given our free market. So one thing to point out is that obviously cross-care solutions be a great benefit. Have the PCP be the hospitalist or vice versa. Studies have shown that there's increased continuity care, better care when the PCP is directly involved. And on the other side, when there's a hospitalist-run discharge clinic, there are certainly improved outcomes as well. However, it's not a realistic option for a number of reasons, and probably isn't one that we would want to pursue unless we had a system that could provide this capitated system, whatever, one where we didn't have to worry about privileges, billing, and that sort of thing. Discharge checklists have been important things that have been going on. Looking at a number of things to make sure are done before the patient discharges, although this didn't really look at any outcomes. And when we talk about this, we also talk about medication reconciliation as a means of improving adverse events, which has modest effect by itself, but not a completely good effect. And another important subject to look at is empowering and educating the patient. Multiple studies have looked at this, but none of them had patient-centered outcomes. But the field that's probably done this the best, I think, is heart failure. They've done a lot of interventions into patient empowerment, education, coordinated care using these single modal interventions, and have shown somewhat benefit in terms of readmissions. But what I'm really getting at here is that it's a multifocal approach to improving the transitions of care process. You have to back talking at the beginning of this presentation, you have to affect a lot of different areas, affect change in a lot of different areas to have a meaningful effect. And there's been a few programs that have done that. The transitional care model is one, TCM as it's also called, has home visits, nursing calls, nursing visits, nurses coming to the PCP's office, education, multidisciplinary collaboration, educating the family as well for when that was important. And it had good results. Reduced readmissions, increased time to first readmission, and decreased cost per patient over the study period of time. Another one to talk about is coordinated transitional care, CTRAC. Had a lot of the same components of TCM. This was done in veteran patients, and while they were an inpatient, they started the discharge and intervention process. Multidisciplinary, multimodal, medication reconciliation, communication with the patient, the provider, education and empowering of the patient. Again, reduction in 30-day readmission that was significant, and a decreased cost involved as well. So these multimodal solutions do work. Another big one to talk about, CTI, Care Transitions Intervention. Again, a lot of the same components, and a lot of these folks around Coleman's 4 pillars, and pretty much any paper I looked at involving transitions of care had Dr. Coleman's name on it. Which 4 pillars are medication self-management, patient-centered record follow-up, and assessment for red flags. Again, same interventions, 48-hour home visit after discharge, telephone call, follow-up, advanced practice nurses providing education and empowerment, and again, lower 30-day readmission rate, mean hospital cost lower as well. So, when we look at the solution, I think going to be saying this ad nauseum, intervention characteristics have to be multimodal, multidisciplinary, intervention and communication across multiple points in the transition continuum, and the intervention, well, this is more for studying. This is a larger view that looked at these multimodal interventions. Of course, you do them, they need to be studied. And these are the 4 highlighted points that I was commenting on at the beginning of the presentation of things that were highlighted on. So now, let's move on to the second part of what was going on between between Rose and the VA across the street. So Matt Hansen, the predecessor on this project to me, was looking at what happens when a veteran is discharged from Rose Medical Center, and also what happens when you're a piece of paper such as a discharge summary at Rose Medical Center, what happens to you. And this is the summation of what he came to, and I'll go to each part in particular. But as you can see, it's a pretty big, complicated mess. So, looking at the first part, if we start here when the veteran is hospitalized, typically at some point the AOD at the VA, which is the administrator on duty, I think, the person who is notified of an admission or something that is related to the VA paying for something, and they authorize this or that. Typically, it's someone either in the emergency department or one of the case managers who's notifying them. Where it's possible that the veteran could, but that rarely happens. Oops, sorry, wrong button. So the discharge process has started. The AOD at the VA writes a note in CPRS that is not assigned necessarily to the PCP, and at the discharge process, you have medication reconciliation, possible new prescriptions, and a discharge summary. So what happens at that point? Well, AOD may make an addendum, but again, rarely happens. The patient or the veteran is typically the one who's calling their own follow-up appointment, which may or may not happen. And they may or may not even say that it's because of hospitalization follow-up. And when they come to their primary care physician's office, they have their medication reconciliation, their patient information, which is largely unhelpful, and the primary care provider mostly is faced with this. Rarely was there any information regarding the hospitalization available, so they have a few choices to make. They can either get the ROI and wait to make decisions. They can have the veteran go across the street here, get their records, which didn't frequently happen. And what mostly happened was that they made decisions based on the scant information that they had, which really isn't the best for care, while they sought the records to see what they were doing. And when you're dealing with high-risk medications like this, such as Plavix after coronary stenting, antibiotics after infection, that's not necessarily the best practice of care. And by the way, most of these veterans are getting the prescriptions filled at the emergency department across the street. That's what will have to happen to them if they fill at the VA, if they don't have prescription benefits, say through private insurance, Medicaid, or Medicare. Now, going back up, talking about that piece of paper, the discharge summary, what happens to it? We go to the right side of our little process map, and most of the time, because that all it's known as the main fax number for medical records, it goes there. I will talk about going to either firm A, B, or C, which rarely happen, but if there was no attention put to it, because there's no way of you guys knowing who the PCP is unless a veteran knows at that time. It typically was shunted to whoever was attending in the clinic at that time. So an OBMT clinic, then they really didn't know what to do. So what mainly happened, though, because this is the interesting part, is it would go downstairs. If the veteran was assigned to a PCP, it would get scanned into VISTA, which they say takes 72 hours, though I will jump ahead and tell you through my own chart review of CPRS and VISTA, frequently took months for the records to get scanned in to VISTA and available to PCP. And that's if they have an assigned PCP. What happened if they didn't have an assigned PCP, the medical records would make some attempt to try and figure out where this needed to be scanned and who it needed to be scanned to, why they even got this. And most of the time, the discharge summary and other information was shredded. And this is a little cleaner flow chart I made about basically what I just talked about, the process. And the typical path, as you can see, the veteran has to make their own call for an appointment. It's typically an OBMT clinic. And for those of you who don't know, that stands for outpatient-based medical training. It's sort of the clinic, it's sort of the urgent care clinic at the VA that is powered by we residents. The veteran typically goes into that because they can get in a shorter period of time. And so the appointment is strictly dealing with that transition process, which was mostly trying to figure out what they were in for based on their own words. Remember, 50% of patients, only 50% of patients knew why they were in the hospital. Veterans being a more at-risk group, probably lower percentage. We typically get a ROI, which would take forever to get in, and a lot of times these veterans weren't assigned, and the records would get shredded even after the ROI and the records were received. So, to the final point, let's talk about what our intervention was here. So, with this in mind, it seemed that there needed to be a better communication system, somewhat multimodal. We did the best that we could with that, and all along and multidisciplinary, all along those points. So first, check with those administrators on duty, I must say, but to be a part of the process. But they really couldn't be. They were, as I said, too busy. They really couldn't even take 10 minutes to look into what was going on, and rightly so. They're dealing with veterans all over eastern Colorado who are getting hospitalized or getting stuff done all over the place. So then we met with case managers here at Rose. Lida was the main person in charge on this end. And we developed a plan of what to do. First, I made sure that they could look up veterans who were admitted, which was an easy process through their system. Developed a checklist for the case managers to follow, which I'll show in a second, to acquire the important information to, and there's Lita right now, send over to the VA, and develop a process map for them to follow. So this is the checklist which I created. This is somewhat adapted from what we do at Presbyterian St. Luke's, and between them and my clinic, Uptown Primary Care, formerly High Street. And it captures the basic information. First, you can see, most importantly, is the veteran. Well, important for me is their social security number, so I can track the data. And for everyone else is their firm association and who their primary care physician is. We collect important information from all persons' points of view, nursing, hospice, why they were admitted, what's outstanding, what is needed, when is follow-up needed, and from the case manager's perspective, important things, not just medication reconciliation, durable medical equipment, home health care, community resources, and other social resource needs. Have any of the hospitals here seen this piece of paper? We got one. So at Presbyterian St. Luke's, which I was trying to bring up here, but it seemed like the case managers wanted to be more involved and fill all of this out themselves. But at PSL, we actually, residents, hospitalists, fill out our particular section ourselves. But the case managers felt fine taking over that duty. And on the this is the second page, which at first, the beginning of this process was basically a checklist, because obviously not everything is back in time. It would be for the case managers to keep track of everything that was sent over and everything that had not been, and it comes with all the firm's fax numbers here at the top. So this is the process map that we took. It was pretty complicated, and whether they had a PCP or not, because they would always need an OBMT follow-up appointment. We tried to get them into their PCP first. If not, we would do a PAC Plus clinic. And for those of you who don't know, PAC Plus is sort of like a primary care physician clinic that's powered by the residents. So we would see all the attending patients, a whole lot of them, but it was all seen by the residents staffed with that particular attending. And and then the process of down here of if not all the information is available at first, what to do here. Again, with a particular firm fax numbers, and we would have them fax the information to the firm that the veteran was following up at, if it wasn't necessarily their primary care physician.
And James, you want to tell them what OBMT stands for?
I did.
Oh, you did.
Outpatient-based medical training. To go over again. So part of this intervention was not just focused here. It was very interesting because the VA clinics didn't really have a system in place for receiving this information. This was, as I said, it was rare for them to get that stuff, so they didn't know what to do with this. So I ended up meeting with all the firms and the leadership of the firm to develop something to do. They really liked that. It allowed them to act quickly on important things such as high-risk, high-needed medications, referrals, imaging, lab work, home health orders, a big thing, especially for those veterans who only got their care through the VA. To point out there's an RN associated with each attending physician, so they got to be involved more as well, and they really wanted to be involved more in the care of the veterans they were responsible for. So they really enjoyed having this set up. The difficult part was Firm A, because they are the resident-only clinic. And for those of you who don't know, we residents at CU are the 4+1 scheduling, which means that we do a month of a rotation and then a week of clinic, no half-day clinics throughout the week like it used to be. So the residents, who are the PCPs for some of the veterans, were only there every 5 weeks, so they weren't consistently there to act on this information. So we set up a system to account for that, with the medical assistant first getting the information, delivering it to the appropriate RN and then an attending physician, and the RN would act on things on behalf of the attending physician as well, because they had the system set in place to contact the patient, to make sure that, to remind them of their follow-up appointment, to make sure everything was okay. They just had no system in place to know when their veteran was admitted or discharged. And then a separate system down here for Firm A, if urgent things needed to be acted on. They have an OB&T box there that the residents throughout the day could look into. And one other thing to point out that made Firm A difficult is that there aren't any attendings in Firm A. The Firm A is staffed by attendings from Firm B and C, so that's additionally complicated things. So we tracked data by getting IRB approval across the street and here. Lita was very helpful with that. First, getting the veterans who were hospitalized here in 2014, and then keeping track of those who were hospitalized here over the intervention period. We collected data. I did a lot of chart reviewing myself. Dr. Austin had the whip out getting you guys do your discharge summaries the same day as what I heard at that time. And the data points we monitored were discharge, diagnosis, duration of stay. We did look at 30-day ED visit or rehospitalization and whether the veteran attended the follow-up appointment. That was pretty easy to track because there was always a no-show note if they didn't attend their follow-up appointment. And then evaluate to see whether the transition of care documents were right prior to their clinic appointment. And that was pretty easy to tell because either from wording of the notes, we residents can sometimes be a little snarky and say, oh, there's no information about the hospitalization during this veteran's appointment. That's an obvious way to tell whether there was no information there. And it was easy to tell because if there was information there, either because there would be specific things mentioned, details, very detailed things from the discharge summary. And some of the attendings were very good about that. They would write when they got the information, Dr. Connor McBride is great at this, would write a summary of the hospitalization and then have the scanned-in documents be assigned to that note that he would write in CPRS, which is really good. Also easy to tell because Vista tracks when the information is uploaded into Vista. sort of puts it in place, if you're not familiar with it, when the hospitalization is dealt with, say May 11th, for example, and then it'll tell you when it was actually scanned in, which an average was a couple months later, so let's say July 30th. So our eligible veterans for the study were those who had their primary care at firm A, B, or C. We wanted to keep it in close proximity as a start to the study to make sure that we could do this at close proximity, because obviously if we expanded to different clinics elsewhere, it would become more difficult with more distance between. Unassigned veterans were eligible too, because they would need to get hooked up with VA, and they had to be on a Rose Medicine surgical service. And eligible veterans are obvious if they were only evaluated in the ED. We didn't take anyone who were associated with other clinics, including geriatrics or Golden. Yes, Golden had a lot of veterans who get their primary care in Golden who were hospitalized here at Rose. Home-based primary care excluded. They're a whole separate service. They have their own separate building. Obviously, if they were transferred, discharged to SNF or TLC, that would, the transition of care process would fall on whoever was taking up care at that point, and if they expired in hospital, obviously. So we'll look closely at our timeline. First, we gathered data from the previous 6 months. This is prior to our beginning of the intervention period. Looked at the veterans who were hospitalized here at Rose and what happened to them. We had a soft start at the end of January after we developed all the systems in place here at Rose, and had a PDS cycle number 1 here in February to assess how things were going with the case managers. Then PDSA cycle 2, I met with the VA stakeholders, and that's when we learned that there was no system in place at the VA. So we set up a system in place at the VA. And May 15th, after a number of different meetings, the process we set up at the VA became integrated into their system. Did a final evaluation the middle of June, and July 1st was our hard start date for our intervention. And July 1st to December, middle of December was when our intervention was in full effect. So this basically summarizes that. There's a pre-intervention period veterans from July 2014 to December 2014, 24 of them. There's the interventional development period, January 2015 to June. There were about 39 veterans. This is when we were getting everything set up. And then our intervention period was from July 2015 through December, and about 41 veterans there. And the outcomes we looked at were whether the transition of care documents arrived prior to the appointment, whether the veterans attended their follow-up appointment. We initially hoped to look at readmissions and ED visits within 1 month, but unfortunately our study wasn't powered enough to look at this at this time. So these are our results. I'll let you soak this in a minute. This is a graph depicting whether or not the transition of care documents were received prior to the appointment as a percentage of time. Now, I cut out, for space reasons, July and August. Also, most of the veterans hospitalized here at Rose were in September, October, and December, but I can tell you none of them had documents here. It was pretty much flatline, 0% in the pre-intervention period. As you can see, during the intervention development period, here in yellow, you start to see some documents arrive ahead of time, and over here, tertiary medians refers to these 6-month periods. So the second tertiary median was this blue line here. About 18% of the time, the documents were arriving prior to the appointment, and at our full-on intervention date, it was going up to 100% of the time, but the median was about 80% depicted by this line. So a definite shift above the overall median for this 18-month period, which is about 22% right here. So huge difference, and that was clutch over there getting that those documents in terms of patient care. The other outcome we looked at in here is whether the veterans attended their follow-up appointment. Also a huge difference here. About 25% of the time in the pre-intervention period, they would actually attend their follow-up appointment. that there was a big increase just with the intervention development period. So making that appointment or starting to attempt to make that appointment had a big effect, and even grew when our intervention was in full effect here, up to 70.7%, almost three times as much compared to the pre-intervention period. The veterans actually making their appointment. So having that communication, having that appointment made, having the documents there, and having the VA know about it so they could reach out to their veterans seemed to help, is what I gathered from this data. So problems noted along the way. We had some difficulty with Firm B's fax number, it not working, it being temporarily down part of the time. The appointment line was complicated at the VA, as the social worker, the case managers can tell you. Sometimes, and particularly this one weekend person wouldn't let them schedule appointments, which that has been hopefully corrected. The transition to care checklist, there was some difficulty, there was some lack of clarity, I should say, communicating everything that should be done with the case managers at that point. I noticed some things were completely filled out when I followed up with them. Not everyone was on board and was generally unclear about everything that we had to do. So again, not powered to look at a significant difference in 30-day readmissions and ED visits, but there were no trends based on our data towards harm with our intervention. And since this was a QI project, we like to look at some subjective results. On the VA side, Dan, RN, and Firm A, that was great. It seemed to work really well. Dr. McBride attending in Firm C, it was nice having the paperwork ahead of time. And Dr. Knutson, attending in Firm B, said it was perfect. We had everything there, the discharge summary, the medication list, the appointment was set up. And on Rose's side, talked with the case manager afterwards. There were a few things to iron out, but one of the big things that they had a problem with that they made clear to me was that the process map was a little overwhelming in its detail. And I initially did that under my mentor's direction to make things very clear, but being that complex made things a little unclear. So we did a simplified version as they could develop their own system and a way of working around things. And this is our new process map we have for our case managers here. Much simplified and basing it off of what they need to do and what they can do. So, looking into the future, one things we can do, expand to other VA clinics, such as the geriatric clinic, the Aurora Clinic. Our case managers have already started to do this. I was hooked up with this clinic, so I'm able to track that. We didn't track that data for our study, but they've already started sending things over to Golden, Aurora. I think Golden as well, right?
We're doing all clinics.
Yeah.
We know about it.
And now they're doing all clinics. We could continue to track these veterans to see if there is a significant effect on readmission, even mortality as we look into the future. Expand to the hospitals. No reason Rose has to be the only one who partakes in this. There are a lot of Hospital Corporation of America hospitals here in the Denver area. And the VA is moving out to the university campus, so that might be something helpful for them at the university campus, Anschutz campus. And we can expand to other clinics, as we already talked about. So just want to quickly go over some things I learned about transition of care. Again, needs to be addressed in multiple levels, multimodal, and multidisciplinary. A one-trick pony isn't going to help anything out necessarily. You need to do multiple interventions to get a significant difference. Communication and patient education and empowerment are clutch, crucial. QI-wise, this is, to our knowledge, the first interfacility transitions of care project that we are aware of in our research and review. This required an enormous amount of coordination. As Lita can tell you, I sent a lot of emails, met with, particularly on the VA side because they love meetings over there, met with them a lot of times, and also over here to discuss things. So, just a little discussion. I'm going to be going into geriatrics here, so this is important to my future, and going to be working with a lot of veterans in my fellowship as well. And so this is the point, and I got us done on a relatively early side to see if there are any questions.
I think one thing that he did an amazing job is the VA system is closed system. They're not used to receiving information from any other facility, even if it is beneficial. As you mentioned, they had no mechanism. The nurse champions, as they're called over there, said, well, we can't even document it because we have a VA authorization to document. We received medical records.
Right.
So it took little things like that, took amazing weeks, months to overcome their system to integrate in. So it is very cutting edge. I think it'll be a national acknowledged thing because we actually bridged the closed system with the communities.
Yeah, that was part of it. Part of a number of the meetings was developing even just a note in CPRS that had to be authorized to get them to track their veterans.
And before his intervention initiation, they would receive records from us, but they'd send them right down to medical records without any reviews. So as much as we were attempting to do that communication, again, they would say they hadn't received anything, but only find out 4, 5, 6 months later that they had. So there just wasn't anything in place to actually acknowledge it. So well done, James. Well done, Rose.
Yes, well done, Rose, as well.
You're part of it.
All right. Thank you, everyone.
Thank you.